Welcome back to Pediatric Case Review. Today we explore a condition that is famously called one of the great imitators in medicine, acute intermittent porphyria. This is a rare metabolic disorder of heme synthesis, and it can fool even experienced clinicians because it mimics a surgical abdomen, a seizure disorder, and a primary psychiatric illness all at once. Have you ever cared for a child with severe abdominal pain but a completely soft, benign abdomen on examination? That striking disconnect is one of the central clues. In this case-based review, we will work through 12 clinical questions covering presentation, pathophysiology, diagnosis, and management. Let's get into it. Let's begin with our first case. A 9-year-old presents with a cluster of acute neurovisceral signs and symptoms following a viral illness. The features include confusion and agitation, severe diffuse abdominal pain, vomiting and constipation, dark reddish-brown urine, hypertension with a reading of 142/92, and proximal muscle weakness. The question is, which combination of clinical features is most characteristic of an acute attack of acute intermittent porphyria? Option A, jaundice, hepatosplenomegaly, and pruritus. Option B, a photosensitive blistering rash, skin fragility, and hypertrichosis. Option C, neurovisceral symptoms with dark urine and normal skin. Option D, hemolytic anemia, erythrodontia, and severe photosensitivity beginning in infancy. The correct answer is C, neurovisceral symptoms including abdominal pain, autonomic dysfunction, and neuropathy, together with dark urine and normal skin. Acute intermittent porphyria is characterized by acute neurovisceral attacks. Severe abdominal pain occurs in roughly 90% of cases, and importantly, there are no peritoneal signs. Autonomic dysfunction produces tachycardia, hypertension, and urinary retention. Neuropsychiatric symptoms include confusion, agitation, and seizures. There is peripheral neuropathy with proximal weakness, and the urine appears dark or reddish from porphyrin accumulation. The crucial point is that unlike other porphyrias, this condition does not cause cutaneous photosensitivity or skin lesions. Now to our second case. A 7-year-old boy presents after a generalized tonic-clonic seizure. He has a history of intermittent abdominal pain, constipation, gastrointestinal illness, and decreased oral intake. In the emergency department, he is irritable and agitated. Laboratory results show a sodium of 126, which is hyponatremia. Urinalysis shows reddish discoloration, and the parents report dark urine. The question is, what is the most likely diagnosis? Option A, acute intermittent porphyria. Option B, acute appendicitis with a febrile seizure. Option C, diabetic ketoacidosis. Option D, hereditary coproporphyria with blistering photosensitivity. The correct answer is A, acute intermittent porphyria. The key teaching point is to consider this diagnosis whenever a child has the combination of unexplained seizures, abdominal pain, and hyponatremia. The hyponatremia here is important because in roughly 25 to 60% of cases, it is mediated by the syndrome of inappropriate antidiuretic hormone secretion and can be severe. There is also a dangerous trap to remember. Antiepileptic drugs, such as phenytoin, can actually precipitate further attacks, so the seizures must not be reflexively treated with these agents. Childhood-onset disease occurs somewhat more often in males. The dark urine is a valuable clinical clue. Our third case. A 12-year-old girl presents with severe abdominal pain for 2 days, along with autonomic and neurologic symptoms. On examination, her abdomen is soft and non-distended with diffuse tenderness. She has proximal weakness, graded 3 out of 5 in the lower extremities, with diminished reflexes. Skin examination is normal, with no rash. The question is, which set of findings is most consistent with an acute porphyria attack? Option A, maculopapular rash, hepatomegaly, and scleral icterus. Option B, an acute abdomen with peritoneal signs, fever, and leukocytosis. Option C, a soft abdomen with diffuse pain without peritoneal signs, plus autonomic and neurologic abnormalities with normal skin. Option D, malar rash, arthritis, and oral ulcers. The correct answer is C, a soft abdomen with diffuse pain without peritoneal signs, plus autonomic and neurologic abnormalities with normal skin. This pattern captures the essential examination findings. The hallmark is severe abdominal pain with a striking disconnect because the abdomen itself is soft, non-distended, and lacks peritoneal signs. There are autonomic abnormalities, such as tachycardia and hypertension, and neurologic abnormalities, such as proximal weakness that can progress toward paralysis, along with neuropsychiatric features like agitation and confusion. The normal skin examination is a crucial distinction because it separates this condition from the photosensitive porphyrias. Our fourth case. A 15-year-old female presents with acute abdominal pain, seizures, and dark urine. There is marked elevation of urinary porphobilinogen, and genetic testing confirms the diagnosis. The question is, which enzyme deficiency is responsible for acute intermittent porphyria, and what is its resulting mechanism? Option A, porphobilinogen deaminase deficiency, causing accumulation of aminolevulinic acid and porphobilinogen. Option B, uroporphyrinogen decarboxylase deficiency, causing photosensitive blistering skin lesions. Option C, ferrochelatase deficiency, causing elevated protoporphyrin and non-blistering photosensitivity. Option D, aminolevulinic acid dehydratase deficiency, causing severe childhood-onset neurologic disease. The correct answer is A, porphobilinogen deaminase deficiency, which causes accumulation of the toxic precursors aminolevulinic acid and porphobilinogen. This enzyme is also known as hydroxymethylbilane synthase. It is the third enzyme in the heme synthesis pathway, and a deficiency causes a partial block, allowing the precursors upstream to build up. Triggers such as certain drugs and fasting upregulate the first enzyme of the pathway, aminolevulinic acid synthase, which dramatically increases production of these precursors. The neurotoxic accumulation of aminolevulinic acid and porphobilinogen then drives the autonomic dysfunction, the neuropathy, and the central nervous system symptoms. Our fifth case. An 11-year-old boy with confirmed acute intermittent porphyria is well managed. His mother asks about factors that could precipitate an acute attack, specifically mentioning an upcoming dental procedure with sedation. The question is, which of the following is not a recognized trigger for acute porphyria attacks? Option A, fasting, caloric restriction, or dieting. Option B, certain medications, such as barbiturates, phenytoin, and sulfonamides. Option C, infections, fever, and stress. Option D, sun exposure and ultraviolet light radiation. The correct answer is D, sun exposure and ultraviolet light radiation. Sun exposure does not trigger acute attacks in this condition because acute intermittent porphyria has no cutaneous photosensitivity. The genuine recognized triggers are the other three options. Fasting and caloric restriction induce the pathway. Porphyrinogenic drugs, such as barbiturates, phenytoin, and phenobarbital, are major culprits. Hormonal